Welcome friends, brothers and colleagues from the medical school. This is your channel Clinical Consultant. In this time we will talk about liver abscess. We previously talked about the epidural spinal abscess. I will leave you the link of the video in the description. I urge you that if you want to know more about the subject, consult your guide texts. Without more to say, we can continue. Definition and type. A liver abscess is defined as a chronic infection of the liver. This infection can be classified as pyogenic and amoebic. Little by little during the video we will understand each one of them. Epidemiology and demography. This is what we ask ourselves, which is the most common? Amoebic liver abscess is more common than pyogenic in the world. In developed countries like the USA, the pyogenic liver abscess is the most common. Incidence. In the world the pyogenic liver abscess is 8 to 5 cases per 100,000 inhabitants. Amoebic liver abscess is usually a complication of amoebic colitis in 10% of these. Most abscess occur in the right lobe. More in men than in women in 2 to 1. They are very common between the 4th and 6th decade of life. Symptoms and signs. Among these the general symptoms, we have fever, chills and sweating, anorexia and weight loss, nausea and vomiting, and also diarrhea. Among the symptoms we also have specifics of the disease, such as cough with pleural pain or pleuritic chest pain, side tip, pain in the abdomen in the right upper quadrant, hepatomegaly, splenomegaly, jaundice. They can appear with pleural effusion, rales and friction rubs. Etiology. Here we have 2 types of hepatic abscess, pyogenic hepatic abscess and amoebic hepatic abscess. Pyogenic liver abscess is usually polymicrobial. Can be caused by E. coli in 33%, K. pneumonia in 18%, streptococci in 37%, P. aeruginosa, Pret. bacteroides in 24%, also by bacteria such as Fusobacterium, Actinomyces, gram-positive anaerobes and S. aureus. Amoebic liver abscess is due to the parasite Entamoeba histolytica. Pyogenic liver abscess can be due to cholangitis disease, gallbladder disease with dissemination due to its contiguity with the liver, diverticulitis or appendicitis with dissemination through the portal circulation, hematogenous spread through the hepatic artery, penetrating wounds, pemioportal, cryptogenic. Incidentally, the risk increases in diabetics and people with cancers. Amebiasis is usually due to fecal oil contamination and invades the intestinal mucosa, penetrating its walls, and reaching the portal circulatory system, reaching the liver. Diagnosis. Differential diagnosis. Cholangitis, cholecystitis, diverticulitis, appendicitis, perforation of a viscera, mesenteric ischemia, pulmonary embolism, pancreatitis. Assessment. Evaluation of a liver abscess focuses on distinguishing between amoebic and pyogenic origin. Some traits that follow the amoebic nature are living in rural areas where water is drunk without disinfecting. Amoebic hepatic abscess are single and not multiple. Laboratory tests are not very specific, although they are useful as complementary tests. Radiological tests are very difficult to distinguish and microbiological studies are only sterile in 50% of cases. Lab tests. The complete blood count shows high leukocytes. Liver function tests show alkaline phosphatase is more or less elevated. Aspartame transaminases and alanine transaminases are always elevated. Bilirubin may be somewhat elevated or somewhat decreased. Prothrombin time is prolonged in 70% of cases. Blood cultures are positive in only 50% of cases. Sterile aspiration is only achieved in 50% of cases. In the HECAS samples we could find trophozoites of Entamoeba histolytica. The serological test for Entamoeba histolytica fails to distinguish between a current infection from a past. Imaging diagnosis. The chest X-ray is anormal, with elevation of the right hemidiaphragm, presence of subdiaphragmatic air fluid levels, pleural effusion and infiltration. This is Amoebic consolidation. Ultrasound, 100% sensitive, shows a heat ground or oval mass. CT is more sensitive to detect hair and extension to contiguous organs. It is the radiological test of choice. Most are solitary, but when there is systemic bacteremia it can be multiple. Treatment. In the treatments we have these three very important aspects to know: the non-pharmacological treatment, the acute treatment and the chronic one. In non-pharmacological treatment we know that treatment of pyogenic liver abscess are distinguished from amebic. Medical treatment is the basis in the treatment of amoebic abscess. Early treatment in the form of surgery, catheter drainage, and parenteral antibiotic therapy is the usual treatment for pyogenic abscess. Acute treatment. Percutaneous drainage under CT or ultrasound control is essential in pyogenic liver abscess. Aspiration of an amoebic hepatic abscess is not necessary, unless it no longer responds to treatment or a pyogenic cause is established. The antibiotic treatment of X is carried out empirically initially with 3 drugs: penicillin, aminoglycosides, and tranidazole. Parenteral antibiotics, such as cefotaxime or piperacillin/tazobactam tranidazole, are used in severely ill patients for 2 weeks, followed by 4 to 6 weeks of oral antibiotic therapy. An alternative option is clindamycin with aminoglycoside or imipidnolone. Antibiotic coverage for AHES includes tranidazole 750 mg/PO 3 times/day for 10 days. Dihydromping 1 mg/kg/day IMX 5 days. Followed by chloroquine 1 g/day x 2 days and then 500 mg/day for 2 to 3 weeks. Can be used as an alternative to tranidazole. Chronic treatment. If fever persists for 2 weeks despite percutaneous drainage and antibiotics is described above in acute treatment, or if percutaneous aspiration or drainage fails, CX is indicated. In patients who do not respond to intravenous antibiotics and percutaneous drainage, the infusion of antibiotics directly into the hepatic artery can be considered. In patients with evidence of metastatic disease with biliary obstruction, a gastroenterologist should be consulted for epiendoprosthesis placement. Developed countries. Forecast, derivation and comments. Most patients with pyogenic liver abscess are fever-free within 2 weeks of antibiotic treatment and drainage. The frequency of healing of pyogenic liver abscess by percutaneous drainage and antibiotics ranges from 88% to 100%. Mortality of untreated pyogenic liver abscess is close to 100%. Most patients with amoebic liver abscess are fever-free within 4 to 5 days after treatment. Mortality of hepatic amoebic abscess is less than 1% unless complications occur. Comments. Complications of pyogenic and amoebic liver abscess include 1. Pleuropulmonary extension causing pyma, abscess, and fistula formation. 2. Peritonitis. 3. Pericarditis. 4. Sepsis. Derivation. Consult with infectious specialties. In some developed countries, radiology, general surgery is recommended for any patient with solitary or multilevel liver abscess. Refer to the gastroenterologist in most of Latin America. Thank you very much for watching the video. Next video will be breast abscess. I hope you liked this video, subscribe and like it. Until next time, greetings.